They are all present in the earlier presentation on so I'll just give you the small gist of that live donor related renal transplantation. So live related unrelated donor transplant. So the live transplantation can be from a related donor as the same blood group, or it can be unrelated also, like a distant friend or another person with the same blood group who is willing to donate. Of course, they have to get the committee's approval for this for all that unrelated donor. With related donor, if it is proved that they are blood related, like own father, mother, or brother, sister, then the rules permit you to go ahead with the transplantation. But unrelated, it has to be approved by a committee formed by the government. So you have to first identify the suitable donor for that, who should have the same blood group, and the age is ideally between 18 to 65. Earlier, they should not have any comorbidity. That was the rule. But because of the paucity of available donors, now they have included people who have mild hypertension or diabetes, but they should have a normal renal function which should be evaluated during the pre-anesthetic checkup. So that is how you first identify them. Then you do the preliminary HLA matching. It's also called as the tissue matching. So how is it done? How is the HLA matching done? Any idea? Ranjini? What is the expansion for HLA?
Human leukocyte antigens.
The human leukocyte antigen, which is responsible for antigen antibody reaction and rejection. Okay? So they should have a properly matching HLA antigen, which will not interfere with the recipient antibody. So that is a very important thing. And this testing is done either by a blood sample or a oral cheek swab. So both these methods are used to find out the HLA matching. And this is the first thing that has to be done. Same blood group or HLA matching. But nowadays we are doing what is called incompatible blood group also. Have you heard of that? Earlier, if it is a O group patient, you require either a O group only, but other O group can donate to other, just like your blood transfusion, they can donate to other groups also. So if it is a different blood group, for example, for A group, if you want to give a B group donor, then earlier it was not possible because of the fear of rejection. But nowadays we are able to do that because we are able to remove the antibodies from the recipient, which will react with the antigen of the donor, and that is called incompatible transplantation, blood group transplantation. So by a technique called plasmapheresis, you can remove all the antibodies of the recipient, which will react with the donor antigen and go ahead and do the transplantation. And but ideally, it is safer to do the same blood group with a good HLA matching. And the donor is usually investigated in the routine fashion or as you do for any surgery, including renal angiogram, which was earlier done by the routine injection of contrast through the vascular route, like doing a regular angiogram for your coronaries and other things. But now we have a technique called digital extraction technology, where you can introduce the dye by simple intravenous injection, and that will go and perfuse the entire kidney, and you can take pictures where it will give beautiful pictures like the anatomy textbooks, where it will show the artery vein, everything in color, and you can identify the length and the size of the artery, the number of arteries or the veins that are subserving. So some anomalous patients may have two or three arteries also, supplying the kidney, and there may be more than one vein draining the kidney instead of the normal single renal artery and single renal vein. So for that, angio is very, very important. And then you can, before 48 hours, you have to do what is called the final cross matching, which is supposed to become as a negative. Just like your blood transfusion, you have to do the cross matching. It will again done by the blood test, and that has to come as a negative or minimum 20% positivity. So last minute antigen antibody reaction is avoided by doing the, so earlier testing, this is called HLA matching. This is called the cross matching. The cross matching 48 hours before surgery is a routine for all live donor transplantation, and that has to come as a negative ideally or positive 20%. Now coming to the recipient is evaluated routinely for any major surgery, and they should undergo hemodialysis 24 hours. Most of the recipients will be on renal replacement therapy only. So unless they are, have you heard of recipients not on renal replacement therapy? Nandini, who are all the
No,
recipients
sir.
who may not be on patients who have normal urine output, who do not have evidences of fluid overload, but patients who have high creatinine and urea value with an ultrasound finding of chronically contracted kidney indicate of medical renal disease. These patients are usually not started on renal replacement therapy like hemodialysis or transplantation, but they are advised to undergo transplantation as early as possible. And they have a normal native urine output of 1.5 to 2 liters per day. So such patients may not be on renal replacement therapy, and the advantage with them is the native kidney will eliminate the water load. It will not eliminate the urea and other waste products. That is why that they all start accumulating. So those patients may not need any hemodialysis, and they will be advised early transplantation straight away. But majority of the patients would have been diagnosed with CKD with a GFR less than 15 ml, and they will be showing evidences of fluid overload because the urine output also decreases, and those patients would have been started on hemodialysis. And the current tendency now is once you identify CKD with a low urine output and GFR less than 15, instead of starting them on creating an AV fistula, waiting for the fistula to mature, and then go ahead with hemodialysis twice or thrice a week, and then wait for the donor. If they have a donor ready and the CKD is diagnosed, most of the patients are dialyzed through what is called the IJV catheter or firm catheter for a temporary short duration of 2 to 3 months until all the workup is completed, and then the donor is evaluated, and if it is related, of course you don't have to go through the committee and everything, and you can straight away proceed with the transplantation. On the contrary, if the donor is unrelated, you make all the evaluations, get the necessary documents prepared, and get the approval and go ahead. So the uh, current concept has changed from chronic dialysis with an AV fistula to a short-term dialysis with a intravenous catheter either through IJV or through the supply vein, which is called the firm cath, and that is the current concept in management of uh, chronic renal failure in recipients. Okay? So that is a new thing. So NPO guidelines for both recipient and donor to be given, and donor to be hydrated with 1 to 2 liters of normal saline during the period of NPO itself. It is not that you co-load after induction. Usually they are given fluids in the as soon as you start the fasting time, you start the IV line for donor and hydrate them so that you can have a good diuresis in them before surgery itself. And pre-op night sedation can be given for both of them with alprazolam, and aspiration prophylaxis can be given with pantoprazole and metoclopramide. But avoid ranitidine, which can cause junctional tachycardia and arrhythmias in these patients, especially the recipient. And you need a OT which has a interconnecting. So it is not done on the same OT. It is done in two different tubes which have an interconnecting door. The donor anesthetic management is done by a separate team, and the routine GA with all precautions for lateral kidney position are taken, like pressure point uh, air and unnecessary hyperextension of the arm on the operating side, and too much of kidney bridge raising to cause compression on the diaphragm and basal atelectasis. So all these precautions have to be taken. And intraoperatively also, you have to adequately hydrate the donor to maintain a urine output of 1 to 1.5 ml per hour. And mannitol 0.25 to 0.5 gram per kg is given when the surgeon starts the with, renal pedicle dissection. That is when you start dissecting on the renal artery and the vein. That is the time you start the mannitol to keep the kidney in a nice diuretic phase. And mannitol also has the ability to remove the free radicals, so that the free radical injury during the ischemia time is prevented. So these are two advantages of mannitol. One, it causes osmotic diuresis and keeps the kidney in a diuretic phase, and second, it removes the free radicals during the ischemia time also. And any intraoperative hypotension in the donor is to be totally avoided. That will cause acute kidney injury. So you must maintain normal ABG values in the donor. And graft preservation, you have to know three terminologies. One is warm ischemia, which starts from the donor pedicle clamp, as we rightly said, to this time of perfusing the kidney with the cold perfusate fluid. Then cold ischemia starts from the time of cold preservative flush to anastomosis and reperfusion. But during the anastomosis time, you cannot maintain the same temperature as you were doing it with the flushing with the cold saline. So what the surgeons do is they pack the kidney with the ice slush around the kidney and in the fossa where they do the placement of the kidney. And some people describe that as secondary form ischemia, even though your only surface cooling is done, not actual flushing is done. So that the flush on the outer side is called the secondary warm ischemia time, because you cannot cool the kidney as you do it with flushing cold saline or the cold preservative fluid. And cold ischemia time is very prolonged in this program. So we arrive at some other institution, and maybe at least 24 to 36 hours sometimes. So until it is kept in cold ischemia time. And that is the reason why sometimes immediate output, urine output does not happen in these cases. So, and what are the composition of preservative fluids? It may change from center to center, but you must have a basic knowledge of the composition. It is basically vinegar lactate, which is cooled to 4 degrees centigrade, to which 20 ml of potassium chloride, 30 ml of lignocaine, which is preservative free, and papaverine and dextrose 25% 50 ml, heparin in units are all added. And some of the commercially available common kidney preservative fluids are called so many different names are there, and their compositions are all given here. The original one was called the Collins solution. It was introduced by University of Wisconsin. And there is another recent one called histidine tryptophan ketoglutarate solution. Then there is Celsius solution, hetatonic citrate adenine solution. There are so many different variations are there. The pathophysiological process related to ischemia, hypoxic renal injury during cold storage include what is the mechanism? Is ATP depletion. That is the adenosine triphosphate production is decreased, calcium overload occurs, acidosis occurs, and mitochondrial dysfunction, oxidative stress, inflammatory response, and cell death programs, eventual death. These are the things that can happen during this ischemia. So, in order to prevent that only, we give the mannitol to the donor, which these reactions are kept to a minimum. And recipient anesthesia is usually GA followed by modification and no IV line on the AV fistula limb or no BP curve. And all the basal parameters monitors should be there. They should take some centers routinely use a central line as well as intra-arterial line for the recipient, which of course I have not found necessary carrier of the transplant recipient anesthesia. But if the patient has any comorbidities, recipient like cardiomyopathy or other compromised cardiac function, then it may be necessary to always have these things. Otherwise, you can manage with a non-invasive monitor itself these patients. And aseptic precautions very very important because these patients will be immunocompromised because of immune suppression, which is given as a pre-medication. Three types of immunosuppressants are used in it. One is the calcineurin inhibitor, second is anti-proliferative drugs, and third is the anti-inflammatory drugs. The examples are calcineurin inhibitor is tacrolimus, is a common calcineurin inhibitor, cyclosporin. Cyclosporin and tacrolimus. The anti-proliferative drugs are mycophenolate, and the anti-inflammatory drugs are steroids, prednisolone or prednisone. So this is called the trinity of immunosuppressants. So all the three will be given. So that is the reason why you can catch any infection, especially lung infection post-op pneumonia is very common. If you are not careful with your asepsis or the management of recipient, you can produce this problem. So, recipient, it can be fentanyl, IV paracetamol. Try to avoid NSAIDs for both the recipient as well as the donor because Ranjini mentioned about multimodal analgesia, in which NSAID is also part of multimodal. So, because the donor is going to be a single kidney person after donation, it is preferable to avoid diclofenac or ketorolac, all these drugs in both donor as well as recipient. So instead of that, you can go for the opioids and paracetamol, special plain blocks or epidural as a method of management. And maintenance control ventilation is often air and isoflurane will be ideal. Of course, sevoflurane with the problem of compound A production is more during low flow anesthesia technique and dry overnight. So that is not a great issue. And you can use, you have to titrate the dose of neostigmine in the recipient because the recipient may have a prolonged effect of neostigmine, which may result in a post-op bradycardia and potential. So it is better to stop the breast thickening once adequate muscle power is required instead of giving the entire 2.5 as you do for any routine reversal. You can titrate the nerve thickening once you achieve the desired muscle power. And with regard to fluids for the recipient, you have to restrict it to maximum 1 liter before the clamp release. That is the anastomosis is done and clamp release is done. And preferably avoid potassium containing fluids. So if the potassium value is normal before surgery, you can use plasma light, which is recommended now. But otherwise, normal saline and half normal saline are used in patients with normal cardiac function. Of course, half normal in patients with cardiac ailments. And fluid replacement after anastomosis is based on the urine output of per hour plus 100 ml. That is the calculation to use. And vigilance is needed at the time of clamp release because this reperfusion injury can produce sudden hypotension, hyperkalemia, and arrhythmia. And mild hypertension is preferred to transplanted kidney in the recipient because it is pressure dependent and volume dependent. And barrier matching is important for post-operative care. So they can again, uh, avoid too many visitors and like this. And all the visiting doctors also should have a gown, mask, and avoid any aerosol contamination. That is, that is that you have to remember. So don't forget to write about the recipient also. You elaborate only the talk. Okay.
Okay, sir.